Hey everyone, welcome back to the Explainer series. I'm Harshal, and I am super excited for this one. In part 14, we wrapped up our look at the application of casts and strapping, right? Well, today we are jumping right into the minimally invasive, highly detailed world of arthroscopy. That's CPT codes 29800 to 29999. If you want to code these complex joint surgeries accurately and, actually ensure proper reimbursement for your practice, you absolutely have to know these specific guidelines inside and out. So let's get right into it.
Here's a quick look at our agenda for today. We'll start with a welcome to arthroscopy, then we'll hit the golden rule, followed by shoulder procedures, knee procedures, scoping other joints, and finally, what happens if scopes fail.
All right, Section 1, welcome to arthroscopy.
Before we even think about looking at a single code in our CPT manual, we really need to understand what the surgeon is actually doing in the OR. So, what is an arthroscopy? In plain English, it's a way for a surgeon to fix a joint using a tiny glowing fiber optic camera and miniature surgical tools. Instead of making a massive open cut across a patient's joint just to see what's going on, the surgeon inserts these tools through very small keyhole incisions. In the medical world, we call these tiny holes portals. And honestly, these portals are a total game changer. They save patients from huge scars, cut down on infection risks, and drastically shorten recovery time compared to traditional open surgery.
Just to picture it, imagine looking at a knee. The surgeon makes these tiny incisions, the portals, on either side of the patellar tendon. Through one portal, in goes the arthroscope, which is basically the camera. And through another, they insert a tiny surgical probe or tool. This setup gives the surgeon a beautifully clear, highly magnified view from the inside of the joint, all projected onto a huge surgical monitor in the room while they work. It's kind of like fixing a ship from the inside through a portal.
Moving right along to Section 2, the golden rule. We have officially reached the absolute, unbreakable law of arthroscopy coding. I'm going to read this exact quote right here, straight out of the CPT guidelines found just before code 29800. Surgical endoscopy/arthroscopy always includes a diagnostic endoscopy/arthroscopy. Let me repeat that because it is literally non-negotiable in the medical coding world. If a surgical scope is performed, the diagnostic portion is automatically included in that code, always.
So what's the critical difference between the two? Well, a diagnostic arthroscopy is when the surgeon puts the camera in just to look around, assess the damage, and figure out what's wrong. A surgical arthroscopy is when they actually insert tools and fix the problem they found. The golden rule means if a surgeon goes in diagnostically just to take a look, but then spots a tear and decides, hey, I'm going to fix this right now, you absolutely cannot build a diagnostic code. That diagnostic looking around is completely bundled into the surgical fixing. You never, ever bill both for the same joint in the same surgical session. Make sense?
Awesome. Let's jump into Section 3, shoulder procedures. Let's get our bearings with the shoulder structure first. Right at the top, you've got the acromion bone, which is a part of the shoulder blade. The area right underneath that bone is a really tight space, and it's actually where a massive amount of shoulder pain originates. When tendons get pinched underneath that acromion, a condition known as impingement, the surgeon has to go in through those portals and literally create more room. And that leads us to two extremely common procedures that you're going to code all the time. First is a subacromial decompression. This is when the surgeon uses a small mechanical burr, think of it as a tiny medical shaver, to grind away a bone spur underneath that acromion bone, stopping it from pinching the tendon. Now contrast that with an arthroscopic rotator cuff repair. In this case, the surgeon isn't just shaving bone away, they're actively using anchors and sutures to meticulously sew a torn muscle or tendon back together and reattach it to the bone. You really have to read that operative report closely to know exactly which mechanical action the surgeon took.
Next up, Section 4, knee procedures.
Going inside the knee, the heavy hitter, the tissue that gets operated on the most is the meniscus. Keeping the anatomy simple, the meniscus is basically this C-shaped, shock-absorbing cartilage pad wedged right between your thigh bone and shin bone. We want to be crystal clear on this, so that when we look at the surgical codes, we know exactly what tissue those tiny arthroscopic tools are modifying.
And here is a vital coding difference you absolutely have to look out for in knee procedures. A meniscectomy means the surgeon is using a specialized arthroscopic biting tool to snip away and remove a jagged, torn flap of the meniscus. They're taking tissue completely out of the knee. But a meniscus repair means they're actually using sutures to sew the tear back together, letting it heal naturally. Remember, removing a jagged flap is coded completely differently than carefully sewing a tear back up.
Section 5. Scoping other joints. Now, obviously, knees and shoulders are super common, but arthroscopic codes exist for almost every major joint these days, including wrists, hips, and ankles. And I just want to briefly remind you here that the exact same golden rule we covered earlier applies whether the surgeon is scoping a hip, a wrist, or an ankle. If they insert the camera to look at the ankle joint diagnostically, but end up fixing a defect surgically, that diagnostic look is always, 100% of the time, bundled into the surgical repair.
Finally, Section 6. What if scopes fail?
Let's talk about a major edge case that trips up a lot of coders. Sometimes, a surgeon starts a procedure minimally invasively through those tiny portals. But maybe the joint is just too damaged, or they can't get a clear camera view. So step 1, the arthroscopic scope fails. Step 2, the surgeon decides they have to convert the procedure to a traditional open surgery, making a large incision to safely finish the job. Step 3, what do you code? You code only the open surgery. If the minimally invasive approach fails and the patient is cut open, the scope work basically vanishes into the open procedure code. You do not bill for the failed scope attempt at all, just the open surgery.
If you bill a diagnostic and a surgical scope together, your claim is going to hit a brick wall immediately. Ask yourself, is your practice losing thousands of dollars to bundled code denials just because of a misunderstood camera view? And that wraps up our explainer on endoscopy and arthroscopy. We have officially conquered the 2000 series codes, which is a huge milestone. Make sure you subscribe to the channel because in Part 16, we're kicking off a deep dive to master musculoskeletal modifiers and NCCI edits. We're going to protect your revenue and stop those claim denials dead in their tracks. Catch you next time.